We would like to present the current technique of arthroscopic Oz Trigonum excision by conventional posterior ankle arthroscopy. None of the authors received financial grants for this study. Advantages include less invasiveness, better cosmesis, and potential for quicker recovery. Does not require a distraction device as well as can be performed with a usual 4 mm 30-degree arthroscope. Disadvantage include difficult to convert into open procedure as required. Can't be done in an office setting. With the patient comfortably positioned prone on the operating table under spinal anesthesia and pneumatic tourniquet control at appropriate pressure, the to-be-operated ankle is strategically left dangling off the edge of the table, allowing it to move throughout the procedure. With the use of a sterile marking pen, the relevant anatomical landmarks are marked out, including the lateral malleolus, the medial malleolus, the intermalleolar line, and the medial and lateral borders of the Achilles tendon. The portals are positioned 1 mm anterior to the borders of the Achilles tendon along the intermalleolar line. The lateral border of the third metatarsal is marked on the plantar aspect of the foot to aid in the trajectory of the surgical instrumentation so as to prevent iatrogenic injury to medial neurovascular bundle. To improve visualization, the shaver is inserted and the impinging soft tissue structures are resected in order to expose the intermalleolar ligament. Both the posterolateral and posteromedial portals are interchanged as viewing and working portal according to the operating surgeon's choice. The intermalleolar ligament is the main dividing structure that divides the posterior hindfoot into two hemispheres. Above the ligament is the posterior ankle joint, and below the ligament is the subtalar joint. In the superolateral quadrant, a hypertrophic intermalleolar ligament is observed, which may frequently impinge on the surrounding soft tissue structures, which is subsequently debrided with a shaver or punch. In the supraomedial quadrant, where the flexor hallucis longus tendon and its fibroosseous tunnel is located, the FHL tendon must be evaluated for tenosynovitis, a low-line muscle belly, and tethering of the hypertrophic ligament against the tendon. Passive plantar and dorsiflexion of the great toe confirms and demonstrates impingement of the FHL tendon against the adjacent hypertrophic intermalleolar ligament. One should be very cautious to not direct instrumentation medial to the flexor hallucis longus tendon. The arthroscope is then directed inferiorly to enter the inframedial quadrant where the presence of the os trigonum is assessed. The entire surrounding tissues around the os trigonum is debrided, demarcated and excised in toto with an oscillating burr. The removal is then confirmed using fluoroscopic images. Pearls include careful initial debridement of fatty tissue is performed under direct visualization of the instrument with triangulation. The flexor hallucis longus tendon is identified through passive flexion and extension of the hallux. Pitfalls include improper placement of the posterolateral portal can result in sural nerve injury. Reckless initial debridement without establishing adequate visualization can cause iatrogenic injury. Incorrectly identifying the flexor digitorum longus or posterior tibial tendons as the flexor hallucis longus tendon can lead to iatrogenic injury.